Good afternoon, everyone. Thank you so much for joining this Annie Research Group meeting. We usually have our meetings every the fourth Thursday of each month. This time, because of Thanksgiving, we moved it a week earlier, so that's why I had to change the URL, the link for this meeting. I hope that everyone has gotten the new URL from my email. So we have a great speaker today, Dr. Kamal Eldeirawi. He is a PhD and also a registered nurse. He is also an epidemiologist and associate professor with the Department of Health Systems Science at the College of Nursing, University of Illinois at Chicago. His interdisciplinary research focuses on individual and neighborhood environmental factors associated with asthma and respiratory atopic conditions, especially in vulnerable and underserved populations. He has pioneered an area of inquiry on the effects of immigration, acculturation, on the risk of asthma and atopic conditions in children of Mexican origin. He has garnered intramural and extramural support for his research and received several prestigious awards. His work has been disseminated widely in scientific conferences, top-tier journals, and media outlets, such as BBC News and Chicago Sun-Times. He is actively engaged with community initiatives and professional organizations. In 2013, he was one of just 12 nursing educators from across the United States to win a highly competitive 3-year grant from the Robert Wood Johnson Foundation Nurse Faculty Scholars Program. Dr. Eldeirawi's research has implications for identifying causes of asthma and defining effective multi-level and culturally appropriate interventions as well as policies to prevent asthma and reduce asthma-related disparities. Dr. Eldeirawi, thank you so much for joining us and accepting our invitation. Please go ahead and add, if you want to add something to the introduction, and then you may start.
Good evening or good afternoon. Thank you so much for this very kind and nice introduction. And thank you for inviting me to this presentation to this important Alliance of Nurses for Healthy Environments. Today, I'll discuss some of my research on living closer to traffic and the risk of respiratory and allergic conditions in children. We are reporting on findings from a population-based sample of Mexican-American children. Move the slide, please. Next. Asthma is one of the main childhood conditions affecting around 14% of children in the United States. Although the prevalence of asthma in Mexican American children is generally lower, or actually lower than that observed for other ethnic groups, still 12% of Mexican American children in the United States have asthma. As you know, the origin of asthma remains elusive, but it's increasingly understood that biological vulnerability to asthma may be related to physical and psychosocial context in which children live, play, and go to school. Studies have found associations of traffic-related air pollution with respiratory conditions. However, the interactive effects of traffic and other individual and family factors have not been well studied. Next slide, please. The purpose of this study is to examine associations of proximity to traffic with asthma and asthma-related symptoms and allergic conditions, and then determine whether these associations are modified by individual and neighborhood level factors. Next. This study was a cross-sectional study. Individual level data were obtained as part of the study of asthma in children of Mexican descent, which was conducted between 2004 and 2005 by my research group and myself. In this study, we collected data mostly by phone interviews from parents of over 2,000 Mexican American children 4 to 15 years of age in Chicago. Almost half the participants were born in Mexico and half born in the United States. Next, please. These are the outcome variables we examined in this study: lifetime doctor-diagnosed asthma, lifetime wheezing, and current wheezing, basically wheezing in the last year, and dry cough at night in the past year. We also looked at rhinitis, defined as, has the child ever had a problem with sneezing or a runny nose or blocked nose without cold or the flu. We also looked at lifetime seasonal allergy symptoms, defined by the question, ever had symptoms like sneezing, itchy, watery eyes, and runny nose with seasonal changes. And these, all the data were self-reported by the parent of the child. Next slide, please. Next. When we conducted the survey, actually, we were not even thinking about neighborhood level characteristics. However, we had the addresses of the participants. We went back, a few years ago, and we used GIS to geocode addresses of participants, and then we linked individual level data with data on neighborhood characteristics aggregated from multiple sources. Next, please. This map shows where our participants came from in Chicago. As you can see, they're mostly from the southwest side and the northwest side as well. Okay, next, please. We obtained data on roads from the Illinois Department of Transportation, and then we categorized participants based on the distance of their residence in 2004 when we collected the data from primary traffic arterials, which were defined as roads capable of moving large volumes of traffic at relatively high speeds over long distances. Okay? Thank you. This includes the list of covariates we examined in this study as potential confounding variables or potential effect modifiers. Next, please. So this slide shows the characteristics and some of the characteristics of the participants and the prevalence of certain conditions. As you can see, the mean age is was around 10 years, approximately equal proportion of males and females. Slightly less than half the sample were born in Mexico. The majority of the parents reported that their children had a regular doctor or clinic. Approximately 15% of the parents reported the presence of smoker in the home at the time of the child's birth. Daycare attendance basically was reported by around
Kamal, we cannot hear you for some reason. Kamal, could you press *6 on your phone to unmute yourself if you are muted? Can you all hear me?
I can hear you.
Okay, Kamal, can you hear me? We cannot hear you anymore. So can you press *6 on your phone if you're talking by the phone so that you get unmuted? I think you are muted for some reason. We still can't hear you. Can anyone else speak so I make sure we can hear you?
Hello.
Yeah, I can hear you, but for some reason I cannot hear Kamal.
Yeah, I can't either.
Kamal,
Can
do
you
you
guys
want?
hear?
Oh, yes, that works now. Sorry about that. I don't know what happened.
Can you hear me now?
Yes, we can hear you.
Okay. Okay, so where are we at? Okay, slide. If you move to the next slide, please. Okay, basically we found no statistically significant differences in the individual level covariates by proximity to traffic. However, those living closer to primary traffic arterials were less likely to be Mexico-born or attend daycare or preschool in infancy, but were more likely to have viral infections in the first year of life. Can you, next, please? With regards to neighborhood characteristics, although we found no statistically significant differences by proximity to traffic, there was a tendency for a lower percentage of Mexico-born and residents of Mexican origin, as well as whites in areas closer to primary traffic arterials, and a higher percentage of African Americans living closer to traffic. So basically, those of Mexican descent live and whites live farther from traffic. Next, please. As you can see in this or in these graphs, the proportions of children with asthma, lifetime wheezing, current wheezing, and dry cough at night in the last year were higher in children who lived closer to traffic and were similar for those living within 150 and those living between 150 and 250 meters of primary traffic arterials. Therefore, subsequently, we combined basically those who live within 150 meters together and those who are living farther than 250 meters together as well. Next slide. Similarly, as you can see, the prevalence of lifetime rhinitis was higher among those who are living closer to traffic, with a nice trend. In fact, the trend here is also significant. Next slide. Also, the prevalence of lifetime seasonal allergy symptoms was higher among those living closer to traffic. The trend here was not as apparent as what we have seen earlier, but overall, these graphs point to higher prevalence of respiratory and allergic symptoms among those who live closer to traffic. Next, please. Here we categorize the distance as within 250 or over 250 from 50 meters from primary traffic arterials. What does this figure show? After adjusting for individual and neighborhood covariates, children who lived within 250 meters from primary traffic arterials had around 120% increase in the odds of asthma and around 50% increase in the odds of lifetime wheezing and dry cough at night in the last year or in the year prior to the survey, as compared to their peers who lived over 250 meters from primary traffic arterials. Next, please. We found similar relationships with regards to rhinitis and lifetime seasonal allergy symptoms. Basically, those who live within 250 meters are also, or we're also more likely to have rhinitis and to have seasonal allergy symptoms. And those relationships were significant after adjusting for a number of individual and neighborhood level variables. Next, please. When we examined whether children who are more susceptible to asthma by having a family history of the disease or a history of allergies, we discovered that the negative impact of traffic on asthma and wheezing was more profound and significantly higher for children with a positive parental history of asthma or allergies. So in this graph or figure, the red circles represent the odds in children with parental history, and the blue circles represent the odds in children without parental history. So basically, the detrimental effect of living closer to traffic was more profound in children with positive parental history, who have the familial predisposition, basically. Next, please. Similarly, children with a positive history of allergies. So this is, we're talking about the children themselves. Children with a positive history of allergies to food or medication were more affected by living in closer proximity to traffic. You see the odds ratios are above 1 and they're statistically significant. Basically, again, showing that the detrimental effect of living closer to traffic on dry cough is more profound in children with a history of allergies. So here we're talking about dry cough at night in the last year. So next slide, please. So what did we find so far? We basically found the risk of asthma and asthma-related conditions, symptoms, and allergic conditions are higher in Mexican American children who live within 250 meters than in those who live over 250 meters from primary traffic arterials. Again, the detrimental impact of living closer to traffic on lifetime wheezing and asthma and dry cough at night and asthma was much higher if the children also have parental history of asthma and allergies, suggesting possible joint effects of environmental and individual factors associated with the disease. These results are consistent with evidence from the literature demonstrating that the negative impact of pollution on the risk of asthma varies by parental history of asthma. Okay, next slide. As you probably know, these results are consistent with previous investigations, basically showing a negative impact of traffic-related air pollution on asthma and allergic symptoms. These associations are biologically plausible because air pollution might induce oxidant injury, which might mediate inflammation. It might also lead to reduced lung function and lung growth deficits and airway remodeling. And this is particularly important because children are particularly vulnerable, and having them being exposed to air pollution, especially early in life, will have lifelong consequences. It will affect the developing immune and respiratory symptoms. It might lead to narrower airways. Also, we need to know that minority populations live closer to traffic or are more likely to live closer to traffic, especially in urban areas, and therefore they experience disproportionate share of air pollution. And that puts them at increased risk of respiratory and allergic conditions. Next slide, please. Our study has several strengths. It's a population-based study, large sample. We have a very high response rate. The response rate was 71%. The participation rate is 91%. Basically, for everybody for whom we had a working address, a valid address, or a working phone, we were able to get 90% of those, and to answer the study, to complete the study interview. Most of them did it over the phone. Okay. We also took advantage of the publicly available data in this particular study, linking individual and neighborhood level characteristics to examine important research questions. However, the study has some limitations as it is a cross-sectional study. Temporality between the exposure variables and respiratory outcomes cannot be established. We were not able to test several potential mechanisms that could explain the effect of proximity to traffic on respiratory and allergic conditions. We did not have, for example, biomarkers of inflammation and so forth. Our exposures were measured using neighborhood data based on the child's place of residence at the time of the study, and did not assess exposures earlier in the child's life or at birth or even during pregnancy. Okay. However, this program of research highlights the role of neighborhood physical context in the etiology of respiratory conditions. We found that proximity to traffic in urban areas increases the risk of respiratory and allergic conditions. Definitely more research is still needed on the interrelationships among individual and environmental factors and how these factors work together and interact to affect the risk of asthma and allergic conditions. Our results have public health and policy implications for planning of transportation lanes, land use, and development of urban centers that should minimize exposure to air pollution and provide opportunities for children to interact with natural environments without really, being exposed to the traffic-related air pollution. I want to make sure I acknowledge my research team and my collaborators, and definitely my funders. This work has been mainly funded by the Robert Wood Johnson Foundation, and some of the early work was funded by the UIC's Provost Awards for Graduate Research. I don't know if I moved fast, but thank you so much for joining, and I'm sorry for the glitch we had. And I would be happy to answer questions you might have.
Yeah, thank you so much, Kamal. That was awesome. So Kamal had a very tight schedule today, but he was so nice to fit this presentation in his schedule. So he has to leave at 3:35. So we have a few more minutes to ask some question. If you would, anyone has any question, please go ahead.
Hi, this is Lisa Thompson from Emory University, and I wanted to ask you about the graph with the odds ratios that were elevated and have had wide confidence intervals. And I was I know you did discuss the limitations of the study, but I was wondering, like, just in your view, what were the unmeasured confounders that you wish you'd measured to kind of narrow that confidence interval? What would be some of the things you seem to adjust for a lot of things that are associated with living close to a freeway, things related to poverty. But I was just wondering if there were other, in retrospect, we all have things we wish we'd measured.
Yeah, thank you so much. And, anytime you do you assess for interaction, basically you're stratifying your data further, and that reduces the sample size you're dealing with. And this is in part why you see larger confidence intervals. But if I wanna, also answer your question about other factors that we did not have. For example, we did not have data on socioeconomic status, other than, whether the child has access to a regular doctor or clinic, which is most of them said yes. However, that did not really distinguish between, did not tell us much about socioeconomic status. However, the participants are from Chicago public schools. So you could argue most of them have, probably a lower SES. So that's one factor we're not able to look at. Other factors such as, mobility, we just had the information about their address at the time of the survey, whether they were recent in the neighborhood or not. We really did not have that information. So that's another variable we do not have, and we think it's important because as you know, pollution probably has a cumulative effect, and exposure to pollution in utero and early in life is very, very, is a risk factor, and it's a recognized factor that has been linked with respiratory and allergic conditions. So basically, establishing the fact that these children were exposed earlier in their life or in utero, we were not able to establish that. It's a cross-sectional. So basically, at the time of the survey, they were exposed or not, or they were living within 250 meters or farther, but we did not have the information about where they were living before the survey, early in life, or in utero.
Yeah, thank you very much for that. I'm an air
Mm-hmm.
pollution researcher, and it's pretty hard to do an RCT on air pollution. So I appreciate the complexities of doing, cross-sectional, even longitudinal studies on air pollution. Always have something else that goes unmeasured and remains confounded. So thank you for your response.
Mm-hmm. You're welcome.
We may have room for one more question if anyone wants to jump in.
Sure, this is Jessica Kastner. I'll jump in with a policy question. If we can go to the last slide with implications. So this is an excellent slide, and I just want to let you know, Kamal, I have personally used this research along with similar research on all children that came out of the California, I think the LA area, in our own region when there was urban planning and master plans, because in the original plan, there was no buffer zone around the interstate. And so I want to thank you for this evidence. I think it informs all of us as we have dialogue with policymakers and planners. Right now, the EPA is looking at the standards for particulate matter and ozone in early December. Given the traffic-related air pollution and what you found is directly related to those pollutants in particular, can you talk to us about any of your recommendations for policy and standardization? Are your thoughts that pollution levels should remain as they are? Should there be more attention paid to near and away from roadways in modeling that informs policy? I'd just like to know your thoughts on how you think this translates into what's happening at the federal level at the EPA right now.
Thank you for this excellent question, and really, I really appreciate your sharing, how this information and these findings are being used. This really is reassuring, and I would really appreciate if you send me, if you have something, written about that would be great, so I can use it. So as far as your question about, policy implications, I think, aside from, the levels, definitely the levels, near highways, near busy traffics are higher. And the problem is when we're building our schools and students spend a significant amount of their time, attending school in the classrooms. So definitely this must be considered when people are deciding on the best location for schools, because it's not only being closer to traffic is the problem. Also, you have the school buses that coming in and out of near classrooms. So I don't have specific numbers or measures now I can share, but definitely the location of the schools should be considered when people are deciding on where to build their schools. I was presenting I think somewhere else, and then one person came to me and she said, I wish I attended this presentation before we just relocated. I said, why? She said, because we purchased a nice house. However, it's at an intersection, and now I'm noticing I am having more symptoms. You see what I mean? So these are very important things to think about and to consider as we decide on where to build our schools and parks and playgrounds for these children.
Well, thank you so much, Kamal. We appreciate your time. We will get back to you sometimes later, probably when you have a new results or new research going on, just to bring you back and then ask you to give us another presentation. But thank you so much. So the other members, would you please stay on the phone, on the call, because I think that we have a couple new members that wants to introduce themselves. Thank you, Kamal.
Very good.
Bye-bye.
Thank you so much, guys, and enjoy the rest of your afternoon.
Thank you. Bye-bye.
Bye.
Okay, so I think that Julia, are you in the call?
Yeah, I am. Can you hear me?
Yes, we can hear you. Would you like to introduce yourself? So, by the way, I'm Azita Amiri. I'm co-chairing this research work group with Luz, but she wasn't able to come today. So, and also I think that for one of our well-known members here is Jessica, and also the other one is Lisa Thompson, that you may need to talk to them later on about your research or whatsoever you want to do. And I will give also some time for Jessica and Lisa to introduce themselves. But go ahead, you introduce yourself first.
Yeah, thank you, and thanks for inviting me into this group. I'm Julia Ryder. I live in Bozeman, Montana, and working on a master's in public health for environmental health, focused on climate change. And I will be doing a research project, or at least trying to gather. There's so little information on air quality in Montana, but it's something I'm very interested in. So this last presentation was right up my alley. So I'm trying to figure out ways to gather information on air quality in Montana and how it's affecting us. Everyone's very focused on forest fires, and we all know those effects, but I think we're missing about how few policies and regulations we have on vehicle emissions and wood stove emissions, and a really rapid growing population and idling cars in the winter. So those are some of the ideas that I'm working with, and I look forward to hearing other research projects and getting more ideas and figuring out more of how to do this right.
Jessica, do you have something?
Welcome to the research group. I'm so glad you're here. That sounds like an incredible project. Can you tell us a little bit about your clinical background?
I currently am I'm a BSN and an RN in the emergency department, and I've been there for about 8 to 8.5 years, and started getting pretty frustrated with the lack of preventative medicine that you see in an emergency department. And so much of it is, like we were just talking about kids with asthma. I mean, we're just seeing such a high level of asthma attacks in kids and adults. Adults have never had asthma before, feeling symptoms. So that's what kind of triggered my need to change and reach out and do something a little broader than just the bedside nursing.
So I'm thrilled to hear that. I'm a PhD prepared scientist. I'm the editor-in-chief of the Journal of Emergency Nursing. Likewise, my background, while I did a year in home health, did end up clinically in the emergency department. And I'm actually thrilled. There's a lot of folks very active in emergency research who are looking at determinants of health and looking upstream of that acute clinical encounter. So what I would love to do is Azita can send you my direct contact information. Let's connect offline and let me see how I can mentor you.
That would be wonderful. Thank you. Yeah, I'd greatly appreciate that. Thank you.
Very good. Lisa, do you have also something to say to Julia?
Yeah, hi, Julia. I am an associate professor at Emory University in the School of Nursing, and I have my PhD in environmental health sciences from UC Berkeley. And when I was there doing my master's and my PhD in the School of Public Health, I was a graduate student on a research project with a project in Guatemala, which was actually a randomized stove trial. I said you can't randomize air pollution, but in the context of people that cook over open fires, you can randomize a stove and see if that improves household air pollution and things like childhood pneumonia. And we actually did a follow-up study in Guatemala looking at asthma, and did follow the kids to 7 years. We didn't find very much asthma or anything really atopic. And now we're doing a 4-country randomized stove trial where instead of giving people a chimney stove, we're now giving them gas stoves and free gas, which has its controversy, but it is the cleanest stove you can provide in areas that don't have good electric supply. And so that's what we're doing there. So I'm very, when you said wood stove, that triggered me because that's what I do, but not in the US. There have been a couple of studies in the US, one among the Navajo who use wood for heating. And there was an RCT actually, I think it might have been in Wyoming or Montana. I can't remember the name of the PI that was an intervention around using wood for heating. And so I think it might have been Montana.
I wonder if it was Butte. Actually, that rings a bell for me.
Yeah, they gave houses HEPA filters. That was the intervention to try to clean indoor air. And I don't have my computer in front of me, but if you look on NIH Reporter and you look, do searches around wood stoves, you'll find it. I think.
Yeah, thank you.
But
I'll do that.
Yeah, it's interesting that you are thinking about this because there are so many different air pollutants that one could look at. But is there a lot of like oil shale? Is Bozeman an area?
Yep.
Fracking.
Yep.
Fracking.
So it's interesting. 40% of the electricity in Montana is from coal.
Okay.
And we have one of the largest coal mines. And it's really interesting because currently I'm in a class where everyone focuses so much on wildfires, and that's the cause of our air pollution. And I think it's distracting us from taking care of really tangible things that we can do. And that's another area that I'm, that I'm getting more and more passionate about. Because, for us in Montana, turning off our lights and reducing our electricity use contributes to clean air because of our heavy dependence on coal. So it's the coal. We don't have any vehicle emission standards in the state of Montana, and we're a very fast-growing state. And so in the wintertime, that really adds up when people idle their cars, don't want to get cold in their cars. And so even at the hospital where I work, there's just so many idling cars in front of the hospital. And we know how that directly affects children. Even from the last presentation, they talked about that. And then probably at least in the town I live in, there's 50,000 people, and I would bet 2/3 of the town uses wood stoves for primary heating during the winter. It's a very popular, hip thing to do, and everyone wants a wood stove, but we all know that they don't fully combust. They're not that clean, So I do think I'm trying to bring people, or my research wants to pull away from the wildfires. As much as I know those are harmful, they're only a couple months out of the year, and I want to be able to make changes with what we can control.
Right. So that's really interesting. I did not know that about the coal and the wood, and it seems like you have a lot of issues to tackle there. I know we had wood fire bans. You couldn't burn when I was out in California. They have spare the air days, and even in the winter, where you could be fined for lighting your wood fire, your chimney. So I think you're at a master's or PhD?
It's just a master's. Yeah, I'm just starting it. I've only done a year into it, so. But yeah.
Well, that's great. You can do a lot. You can do a
Yeah.
lot. You can write a paper. you can collect your data in the ER and write a paper, and just it could be an assessment of knowledge around these issues that are done with patients. But anyway, yeah, if you have any questions, just email me, or we can arrange a time to talk when we have more time.
I really appreciate that.
Yes.
Yeah, thank you.
Very good. So we have also Claire on the phone. Do you want to introduce yourself, Claire? Can you speak? I see you are muted. I don't know how you got muted, but go ahead and introduce yourself if you can. I don't think we can hear you. Do we have anyone else on the call who wants to introduce herself? So, Julia, my area of research is indoor air. I work with the footprint of nurses at the hospitals and indoor air that may harm themselves, like crushing medication and cleaning and all those stuff. And also in indoor air in houses. I do the research in the United States mostly on VOCs and formaldehyde and particulate matters. I measure those with my instruments, and then trying to find the sources of those pollutants, and also how to be able to come up with some solution to eliminate the exposures of children and high risk population. So I'm sorry, Clay, that we cannot hear you. Can you text? Okay, but oh. So okay. All right. So we will talk to you in another time for sure. Thank you so much for coming. Thank you so much, everyone, for coming. Julia, do you have any other questions or something that we can help you with?
No, that's a great start. Thank you for the support.
No problem. And I will send you both Jessica and Lisa's contact information, so you can definitely talk to them.
Thank you very much. Thanks, Jessica. Thanks, Lisa.